That's the
Oh
channel.
my
I
God,
know,
it's just-
it's going. We're
Oh my
live!
Hi guys.
Hello!
This is very weird. We don't know if they're watching or not. We don't know.
Okay.
Oh, okay.
It's
there
really
we
nice
go.
back there.
That's
Right.
better.
So welcome to our first ever live stream. We have never live streamed before. This is the
gonna be
first
shambles.
time.
It is gonna be actual shambles.
Hello! Oh, hi Matt! Hi Jay! Yay! Yeah, Jay and Matt so far. Hello, welcome. So to answer your question, Jay, it could be anyone. We're primarily doing this for University of Exeter First Aid
Thieves!
Society people.
Thieves!
But if you've got friends, let them know. Hi Phoebe, hi Sophia, hi I'm Mary. We're here. Please bear with us. This is our first time doing it online. It's a little bit new for us. I'm sure it's a little bit new for you. But please do keep on commenting. We're going to try and do our session on a lot of scenarios, just like we usually do in our last session. So we're hoping for a lot of audience participation. Woohoo! So get in those comments. But it's really lovely to see you all, kind of, in a way. I hope you're doing well. We've got a couple of announcements just to start off with. You found yourself here. Hooray! Step one. This is the same live stream YouTube channel that we're going to use for our AGM next week. So if you are wanting to vote, if you're wanting to just watch, if you're wanting to nominate yourself for any of our committee positions, I do recommend kind of popping onto our live stream next Wednesday. It will start at 6 p.m. And just kind of following along the proceedings. Jono and I will be here by ourselves. Woohoo! Kind of going through the whole AGM process, but everything will be online. So online hustings, online voting, and we've got some more details for you just coming. I know it's a very different kind of situation. We're taking it as it comes. I'm very, very sorry for all of the confusion and all of the updates as we go, but thank you for being so on board with it, and thank you for being so nice about it. I hope that you're all excited to get involved. If you are in any kind of different time zone, I am really sorry. Happily, every kind of live stream then gets uploaded. So if you want your EUFAS fix, you can watch it at a more convenient time later. Hooray! So if you are interested in the AGM, there's a lot of details about what you need to do. You don't necessarily have to send in a 5-minute video of your speech. Any kind of equivalent is lovely. So a written down version if you don't want to record yourself, a voice recording if you don't want your face on film, anything. Just message me and we can sort something out. But if you can email them to my personal email, which is on our Facebook group, not on the general internet.
Good plan, yes.
And please send me then by next Tuesday, ideally, but the nominations period will close between each role. So if you don't get the role that you wanted, you can nominate yourself for a later one, and we'll kind of dynamically go as it goes on the AGM day. So that's it. Take a look at the AGM event. If you have any questions, please do message us. Hooray, AGM. Other than that, I hope that you're all doing well. I know it's a lot of change. I know that everything is kind of continuously progressing, but first off, you're here. Hooray. We're so happy to have you. And I hope that you're all safe and well. And if you ever feel uncomfortable or not in the best place as we're going, please do message us. We're here for you. There's also a lot of kind of wellbeing services available. Nightline now has an email service that's going to be live until the end of term. The Samaritans are staying open. Please do reach out if you need to. And we're always here. Hooray. So with that, let's get this party started. So we're going to do some scenarios for you. We've worked through a few. Thank you so much to Jake Harvey, our lovely AFA. He's come up with some really nice scenarios. He couldn't be here today, but they're really, really good. And we'd really love to kind of go through them and show them with you all. So as we go through, please do message in the little comments or be watching. You'll see me kind of come very close because I can't really see. Didn't leave my glasses at home. And yeah, we'll kind of go with that. But yeah, this is kind of awkward because we don't get any feedback back, but hello, thank you. Hooray. Okay, so I'll hand you over to these guys.
Okay, hi guys.
Hand you over to these guys.
I'm still here. We're all here.
I feel like this is the strangest thing we've ever done. Because we're so used to bickering amongst each
Yeah.
other.
and then like everyone's watching us, but
Yeah.
here like everyone's watching us, but we don't know that you're
There's
there.
no one to diffuse the bickering, so we don't really know what to do.
It's gonna be really weird.
We're gonna just start talking amongst ourselves, and then
Yeah,
it's
we're just gonna
get
have a
weird.
chat, and then you're gonna be like shouting at us, like, "Please, no, stop!" But no, we will not stop. There is no stopping us. The
We can
blonde
just
one.
flip the argument. No, they are integral.
Also, no, I'm sorry. We have no stash. My stash is in the wash. Please wash your clothes. If you're concerned that you've come into contact with anything, wash them.
Callum's asked me what is supreme.
No,
Jono
Jono
is
is supreme.
Okay,
That's cool.
like a veggie supreme.
No, you're just supreme.
Oh, thank
Why
you,
is he
Callum.
supreme?
I see.
Oh la la. If you
Oh my god, we're gonna get so distracted.
Anyway, okay, right.
Cringe, like an outtake, but it's just
Stop,
ultra.
stop.
You know.
Okay. Oh my god, the whole thing will be an outtake. It's fine. We've got to put this aside. Why are you watching us?
So-
Jono is watching us live stream as we go.
So
It's
that we
also
can
like
see the
5 seconds
comments
behind.
on
Ooh,
this
they're bigger.
Can I
laptop.
see how behind it is?
It's
Your
easy
comments
to
are
watch it on
bigger.
my laptop than to
Oh.
like come up really close.
Okay,
to
I
the
also
parents'
have a
laptop.
question. I need someone
What is
to just
PogChamp?
write in a paragraph, like, what is a pog?
Zoe,
What
hey!
is a champ? What's a PogChamp? I don't know. I'm confused. I'm getting with the details. I'm not a youth. I can't do this. I feel like
Hey,
a
Anna.
mother. I am a grandma. Help me. So just give me a quick paragraph.
Press
As you're writing that,
pop out
we'll
of
start
chat.
with the scenario.
Yes, let's do some stuff.
Okay.
Well, we're gonna teach something first.
Yes,
Yes,
we
you
were.
are.
So we'll teach through some things
Am I
because,
gonna be?
as you may know, an AFA or an advanced first aider in St. John is slightly more trained than a first aider. So your first aiders are very, very valuable and very, very skilled at taking the basics. So basic observations, your staples, your temperatures, your respiratory rates, your pulse rates. But then sometimes as you... Isolation is so hard. Sometimes when you have a more challenging patient, you need to take some additional obs. So things like your blood pressures, things like making sure that you're allowing specific interventions. So that's where Jono and I talked to you about medical gases last week. You need to start using Entonox, you need to start using oxygen, you need to start being able to take observations like your oxygen sats so that you can deliver those interventions safely. So advanced first aiders can do slightly more and they have a little bit more in the ways of clinical judgment. So we'll explain to you a few things that kind of form the foundations of these scenarios, and then it will be up to you to tell us what we would do in them. So let's
It's
go.
gonna be like Dora the Explorer, where we like, what do we do now? And then there's gonna be silence.
Yeah.
And then somebody's gonna comment, and then we'll do it.
Please,
We'll be like-
can you guys please make sure that you comment like the
Yeah, please.
answers, because otherwise we're gonna sit here in silence, just like staring at the computer.
Eloise says that we look like we're being held
I honestly feel slightly like,
We
yeah.
should just start
We
like
are.
holding signs up, be like, we are at X and Y. Please save us.
Also, no one has still no one's told me what PogChamps are. Also,
No,
yeah,
no,
Dora
we
the
did. No,
Explorer.
it did
What?
happen.
What?
It happened way
The
far.
chain thing, like
Chain
four
thing.
person type PogChamp.
If
What?
four people type, oh, is it like that candy killer thing?
On Twitch,
Candyman,
you use
where,
them
like-
notes by typing a string of text, and PogChamp is one of them.
What's Twitch? Is that like
It's what they're
oh?
using
is
to
it-
do the
What's
lectures
that like when they dance?
Samba.
TikTok.
Oh my god, what?
Okay, let's get on with the session.
Anyway, chuck me that helmet.
If you're having fun,
I
make
feel
sure to
a
like
grandma.
and subscribe.
I hate that so much. I hate
Drop a
it
thumbs
so
up in the
much.
comments.
I hate that so
Yeah, what's
much.
Twitch? Like, why?
Emma, get over it.
Koso!
It's going to be on YouTube forever.
Yes.
Oh
Oh,
god!
Okay,
Whatever.
it's fine.
Right,
I'm a
where's
grandma.
my? I'm gonna.
Like
So
that.
This is gonna be so fun. Right.
what we'll do is we're trying to combine a bit of theory and a bit of practice. So we'll talk it through, but also we're going to have some handy dandy demonstrations
Oh God,
as we
it's
go.
so weird lying in a helmet.
Okay. Off you
Your head is so small as well.
go.
So when you remove a helmet, it's a two-person job. We normally kind of use 2 AFAs, preferably, or like a advanced first aider and just a first aider. Or
Just so straight in front of the camera.
Sorry.
So bad.
So my living room is quite small, and it's very difficult to like, work all around. Like, you might want to tip the laptop down a little bit so we can see Aaron a little bit better.
Or we can.
Yeah, that's fine. No, that's fine.
Hello.
So whenever anyone has a spinal injury, you'll always have one person immobilising the head, and that's kind of why we need to use 2 people here. So we need one person to immobilise the head, and then we need the other person to remove the helmet. Aaron's got a bike helmet on today. It's an official St. John stash helmet.
Stash.
Removing bike helmets can be quite difficult. This helmet is kind of pretty straightforward, but as AFAs, we're also trained to remove motorbike helmets, which requires a lot more because there's kind of face shielding, and you have to do all sorts of different manoeuvres to squeeze that off. But we'll just go through taking off a bike helmet for now. You'd only kind of need to do this if you're worried about spinal, but that's quite common. If somebody's been riding a bike and they've fallen off their bike, you might query a spinal, so it's quite common. If they're able to just kind of, if they're walking around and they've already taken their helmet off, then it's fine. But this is, if somebody's come off, you're worried about some kind of spinal injury, you want to do it in a very controlled way.
Before we go on, it's Dora the Explorer time. In the comments, when would you suspect a patient having a spinal injury? What might indicate that your patient is in any way damaged to their spinal function? Answer me. Ho, ho, ho.
Oh, that's just like
Yeah, I'll be looking at the comments.
my helmet is, my head is so small.
Wait, I'll just a sec.
I'm sorry.
We're doing a Dora the Explorer moment.
Dora the Explorer, what? We're all just going to stare.
What kind
at
of
you.
signs would you be
I can
looking
get
for?
my-
Oh yeah, loss of
Correct.
sensation, falling over, hit the. Oh, brilliant!
Yeah.
Inability to move. Aaron, stop moving your head. You have a spinal. That's true, Phoebe. Thank you. He needs to stop moving. He needs
Yeah,
to stop
okay,
talking
so
in
Aaron's
general.
not being a very good spinal patient.
Well, I just
But this is very fair.
That was not very good.
So when you're dealing with a spinal patient, it's very important that, unlike what Aaron is doing, moving about, when you're asking him questions, when you're talking to him, make sure that you're right by his head. Make sure that you're not asking questions where he's going to answer and nod or shake. So avoid the yes/no questions. Ask open questions. Make sure you're maintaining eye contact so he doesn't have to strain and move his neck. And just make sure that he's keeping calm and still.
Yeah, so it's pretty similar with a motorbike helmet. Normally you'd want to immobilise from the top of the head. When removing helmets, you kind of want to immobilise from the side, because when you take off the helmet, you'll be removing it vertically. So Emma will take the helmet off that way, and if I'm holding him like that, then it makes it very difficult to move it that way. So how I want to hold Aaron is I put one hand kind of around the back of his head, right in like the small of like the neck. Yeah, if you lean forward.
Okay.
So put one hand kind of like nicely in there and get a really good grip so that I can't move. And then one goes on the chin, but you've got to be really careful that it's right on kind of the jawbone. I'm not going with the neck because that's not protecting the neck, but also I'm literally strangling Emma right now. So you want to kind of come in on the jaw, grip around the jawbone at the sides, and then you'll grip quite tightly there, and that's a really good grip there, and she won't be able to move. Once we've got the helmet removed, then we can readjust, but for now that's kind of the position I'm going to adopt. So I'm going to take that position. There's not enough room. There's not enough room in my living room for this.
Ideally, as you kind of already know when you're doing, if you've done this before in our scenarios, ideally when you're ever on the head, you're using that kind of spot grip and you'll be lying down here. There isn't a lot of space here, but whenever you're doing anything like immobilizing, whenever you're trying to take a helmet off, ideally you'd be lying down. Of course, pre-hospitally, you're in different settings, like now, where I can't lie down, but that's okay. So the first thing that you ever want to do when you're removing a helmet is there is no point pulling the helmet off if the straps are still attached. So now that Jono is immobilizing Aaron, now that I know that he's going to be okay when I start fiddling, I will then start kind of looking at the strap, seeing how I can undo it. One thing to note with motorbike helmets is they're very expensive. And if you start producing a pair of tough cuts, which are basically massive trauma scissors or trauma shears, the person can get quite agitated and they're like, no, don't cut it because it's hundreds of pounds. Although hopefully they're going to invest in a new helmet anyway if they've come crashing off.
Mm-hmm.
But ideally, you don't really want to
Really
be.
shouldn't be.
You need to get a new one.
You need to get a new one. Ideally, kind of you cut it off or you just kind of undo the strap. I think this is just a normal strap.
I
So
think
you
if you
just-
cut this off with Tough Cut St. John would not be happy with you.
I dare you.
So you undo the strap, part 1. The next thing I'm going to want to do, you're working as a team, so I'm not just going to randomly pull. Jono needs to know when I'm going to do it. So just like the same with using a carry sheet or any kind of manual handling techniques, we'll use the ready, brace, pull, ready, brace, roll kind of situation. So when I'm ready to pull that helmet off, I'm going to let Jono know, because as soon as I take the helmet off, there's going to be a gap between the floor and his head. So Jono's going to have to really work on stabilizing and maintaining the heaviness of the head, the weight of the head, because it can be quite heavy and it's a difficult kind of position to go with. So are you ready, Jono?
Yeah, ready?
Okay, ready, brace, pull, and I'm literally just going to pull
Oh, that feels so
nice and slowly, working with the head because it's going to pop round with the shape of the helmet.
Take your
Yeah,
seconds,
I'm taking this out,
Okay,
and then I'm going to slot here.
you've got hands on.
I've got hands on.
I've got hands off.
Okay, and then I'm going to very slowly
So supportive.
place his head on the ground in neutral alignment. And then I'm going to maintain my position here. If I then got uncomfortable and needed to move or someone else needed to swap in, Jono can then come back in the same kind of position, so on the jawbone and the forehead.
But you could also go underneath if you wanted. But here, because we've got his full head exposed, this kind of gives, because I'm kind of holding both ends of his head where there, I've only got bottom support. Here I've got support at both ends of his head.
Okay, do you have hands on?
Hands on.
Okay, then I'm going to let go. And then somebody else can slot in here. Basically, you always want... Whoa. Okay.
We have some questions when you're ready.
So you always want somebody to have hands on at any one time. This is when you could start thinking about, are we going to put him in a collar? Are we going to kind of physically maintain his spine? What are we going to do here?
Okay, so we've got Cosmo. Hi, Cosmo. Asking, are you doing this prior to or after the secondary survey?
You kind of probably want to do this as part of the secondary survey. So kind of when you're going head to toe, you need to expose the head because he could be bleeding underneath. So you do it in order to do a good head to toe survey. You definitely kind of want to have some kind of history before. You'd want to make sure that you have like the staff, the assets there to help you. But you can't, like, if you don't know what you're doing, then leave the helmet on. But if you do know what you're doing, then you take it off as part of the secondary survey.
One of the major reasons for taking motorbike helmets off or any helmet off is if you're worried about their airway. So think of the doctor's A to B in St. John.
A to B. All 2 letters that are included in that.
You're going to want to start with C for C-spine. If you're worried about a C-spinal injury, that's going to come up, especially in the prioritization. If you're worried about they're not breathing, they can't maintain their airway, you're going to want to get that helmet off so you can then put any adjuncts in, make sure that they can breathe and stuff afterwards.
We did have another question. Where's Jay's?
Cosmo's given us a follow-up for that. Just because it's the same question,
Yeah.
and we can do others with it. So he says, on that note, so bearing in mind what we've just said, are there any contraindications to removing a helmet?
I think if they tend to say if you don't have, well, obviously if you don't have the people to do it, if you can't physically get it off because there's only one of you, then don't. Also, if they are stable and they can breathe and their airway is patent and open and fine, and there are other things that you can be doing, they tend to say just leave the helmet on, just because the helmet is naturally kind of maintaining the C-spine. It's up to you.
Especially for like a bike helmet, like this isn't. Oh, I can't reach it.
It's not really.
It's not like it doesn't really get in the way of much. It's quite convenient because it's got lots of holes in, so you can like see through. So like you can see if there's any obvious bleeding or any kind of deformity through the helmet. So like you might be able to get away with it if it's all about that kind of that toss up of what's more important, kind of having a look at the head or the spine and the airway, which is why I say if you know what you're doing, then crack it off.
Yeah.
But if you don't, kind of that's why you leave it on.
I mean, for motorbike helmets, I would say don't remove them unless it's necessary, because it's a large maneuver and it's quite risky.
Yeah. It can be
It
quite
can
time-consuming
be quite
as well.
risky.
Yeah.
So unless you really need to, I would say you can leave it on, especially if the patient is comfortable in it. Then
Yeah.
Yeah.
like go ahead and just leave it there.
You will find that often people kind of want it off because it some motorbike helmets, they're quite nice because like there's kind of like a jaw piece that slides up, but some of them it's kind of full face and you just get their eyes. You can't really assess their breathing. You can't see them. It also makes it really difficult to understand. So if they've got that helmet on and you can't do your basic assessments, you can't kind of check pupils, you can't see what their face looks like, you can't hear them answer questions, then that's why kind of you take it off. I don't really think there are many there's no kind of medical contraindications to removing a helmet as far as I'm aware.
No.
But if anyone can think of any, put them in the comments.
Yes, this is an AFA skill.
Yes. So if you're a first aider or if you haven't been trained in removing a motorbike helmet or any kind of helmet, then please don't do it. That would be a very good contraindication. Right. Any other
Also
questions?
Sorry, I just saw Jay's question about the brace for lifting.
Mhm.
It's not really about for heavy lifting only. We use ready brace.
Yeah.
It's not ready brace lift. It can be ready brace anything. It's just so that everyone who is part of that movement is ready for that movement. It's like saying ready, set, go at the beginning of a race. Saying ready brace, pull, ready brace, up, ready brace down is just a way for the whole team to know, right, we're doing something now and I have to be ready. So in this case, it would be Jono has to be then ready to take my head in his hands so that he's got that weight before Emma slots her hands back on.
It just lets everyone know. So Emma, because obviously she's calling it in this scenario, she knows what's going on. But it helps me to know. It also kind of helps the patient to know. Sometimes it means that if I've been talking to Aaron, I can say to him, okay, we're taking your helmet off now. Because it feels strange for it to just kind of suddenly come off. Also, whilst it's not really heavy lifting, in the position that I'm in, all the weight was going through the back of the helmet. Because obviously there's like that inch or two of like the helmet that all the weight's going through. And then suddenly it's all on me. And like, it's not heavy lifting, but I'm suddenly taking a significant weight of Aaron's. And I said to Emma, I need you to take his head now because trying to hold it on the side, you're not engaging any kind of real muscle groups. So trying to hold Aaron's head up perfectly like that is actually really difficult. And it would be very easy for Emma to kind of pop off the helmet, for me to not be ready, and his head would have gone bump and gone right down back, which obviously isn't good for your C-spine at all.
if you had to try and post your head, it would be really expensive because it's quite heavy.
Yeah, your head is quite heavy. If you've ever like held a baby, you always need to support their head because their neck isn't. It's quite heavy, and so they can't really support it through their own strength alone or through their neck. So it's really important that you support that head. It's the exact same when you're dealing with any kind of spinal injuries, because when you are supporting it in that really strange position, it is fairly heavy. It's quite heavy anyway, which is why you just need to make sure that everyone's kind of ready for you to whip off that helmet.
Aaron is a baby. Agree.
He is a baby. He actually is my child. Right.
I'm trying to find a
Hospital, aka Jono's living room. Honestly, we hoovered it today. It
it's
was
the
a bit
first
of a
time it's been
mistake.
in ages.
I do feel like we're in one of the like. We are in the wild. It is pre-hospital.
Yeah. And Ash, yes, I think it would. A lightsaber would cauterize a wound. Yes. And they did do that.
It does.
It really does. That's why when Luke got his hand cut off, he didn't bleed.
Yeah.
It just straight through.
He didn't put a tourniquet on. He didn't need it.
Yeah.
When you guys are asking questions, just because it's amazing we've got so many comments coming through. Can you guys just put like question.
Yes.
So then we can find it because there's so many comments. We're like
that would be
trying
amazing.
to filter through to find your questions.
Yeah.
If you just put question and then
Indicate
the
it.
question, that will make it so much easier. So we don't spend half the session just staring at the laptop trying to work.
We're like reading
And
really quickly.
Pat, can we get a shout out for Aaron's knees? Yeah.
What?
You're shouting out
What's wrong with
Aaron's
his
knees.
Why are you shouting out my knees?
Because they're cool.
Aaron's
I don't
knees.
know.
Question: can we get a shout out to Aaron's knees? Shout out to Aaron's knees. If you like Aaron's knees, give us a thumbs up in the comments.
Aaron's knees gets its own YouTube
Oh my god,
channel.
please! I want to see how many thumbs up I get
Ew.
now. For my knees.
Okay. Right. So.
I look so shocked. It's so funny because there's a delay between us filming and then it coming up on my
Yeah, it's
laptop.
weird.
So I do something and then I look at my laptop and I can see like my own response and I didn't realise how
Question.
active my face was.
Yes. Good demo of questions. Thank you. Thumbs down for the knee.
Ouch.
Bad times.
That's shocking.
Hello,
I'm just gonna
knees.
leave now.
Newton.
Oh, damn. Okay. Dang.
Anyway, right, what's next?
So
Okay.
that's how
What's
you
some
remove
scenario?
Can we
a
move
helmet.
back?
Shuffle.
Okay, so should we go on to the scenario?
Yeah.
Okay, so this is a shout out to Jake Harvey who wrote these scenarios and basically planned all of this for us. So you were on patrol and a motorbike is driving down a road when suddenly a car speeds around the corner, collides with the bike and drives off. Hit and run, guys.
Oh my god.
The motorbike rider is flung from the bike and lands on the pavement. What is the first thing you should do?
Put it in the comments.
Story of the Explorer time.
What's the first thing
What's
you
the
should
first
do?
thing you should do?
We should all just like freeze.
Yeah, we're gonna- Correct.
Yes.
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 In it.
Danger.
Nice.
What map? Ash, no. Get that map
Where's
out.
Boots?
Oh my god.
Um,
Boots. I'm gonna ignore this. So yes, the first thing is danger. If you're in the middle of a road, what is the best way to make sure that other cars will not drive over you and your patient?
Do you have a car or are you just by yourself?
My cars? Oh wait.
No, as in,
Oh,
are
I
you-
thought you were asking
Are
about
you
my
in
car.
a
No, it's real, it's
vehicle? Are you in a vehicle?
Let's say that you were driving along in your bright yellow car and then an accident just happened in front of you and you have stopped. What's a good way to make sure that that patient will not be hit by a car?
Swipe a nose swipe. You see Ash's comment.
Swipe her nose.
Uses me. Okay, so ask a friendly neighbourhood vehicle to block the road. That's really nice. Thank you, Anna.
High vis jacket is a really good idea.
Jay's really on it. It really depends on the road. Not great on the motorway. You're not going to want to be doing that. The best thing to do there is if it's in the hard shoulder, you want all the people to get out of the car. If you have a breakdown on the motorway, you shouldn't be staying in your car on the hard shoulder. Please go on the embankment. But if they need to stay in the car and they have to, that's where you really need to call 999. The police will come and deal with that. Hazards is a really good one. If you can park in front of it and have someone else behind it, make sure your hazards are on.
Similarly, when you're parking your car behind any accident on the road at any point, don't park 3 inches from the accident because you will most likely become part of that accident. So if you are parking behind an accident, stop a good 50, 100 feet before that vehicle. Stick your hazards on and make sure you yeah.
I like the
Honestly,
hazard
yeah.
lights, parked anywhere lights. Very real.
So if you are going to kind of use you or somebody else to be slowing down traffic, what you don't want is you don't want to be stood in the road. What you can do if there's like pavements and stuff, if you go a good distance away from the accident, stand on the pavement, stand on the hard shoulder, and preferably in some kind of high vis, and you can kind of like do that sign and it shows people to slow down and warns them that there's an accident ahead. It's more about giving people like kind of the caution, the warning up in advance, so they know that they're coming up to something, rather than you standing in the road like Gandalf, you shall not pass, because if a car going at 30 miles an hour, if they suddenly come around a corner or come over the brow of a hill and they see you stood there, high visors are great, but they're not going to stop that car in time. And also, if you're really, really close
High
to
vis
that,
versus car.
honestly, man, and if you're really close to the accident, or the incident, I can't say accident anymore.
Ooh.
It's
Yeah,
against
that's true.
official vocab guidelines.
That's actually true.
Shout out to Hot
It's
Fuzz.
real.
I don't know if I can say that. We'll probably get pulled down by copyright.
Yeah.
Anyway, yeah, if you kind of stood too close to the incident, people don't have enough time to slow down. So if you stand a good distance away, like 100 meters away, people know that it's coming up, and then they'll see the traffic building up, and then they'll stop in a timely fashion, rather than kind of a sudden, oh, bugger, there's an accident, slam on the brakes, and then you create a new accident. So yeah, kind of go further up the road.
Okay,
So
lovely.
if we're thinking like this is an in-town situation, so in Exeter, and this biker was flung onto the pavement, so luckily you don't have to stand in the middle of the road or anything.
It's a very convenient scenario.
Indeed,
Yeah,
yeah. So he's on the pavement, which is great. But what you have to be careful of when you're looking for danger is like crossing the road if you're on the other side, or like looking for other obstacles like cyclists who are crazy and cycle really fast, and obviously other cars that might hit you if you're crossing the road to like run to the casualty. But no, you're
Don't
not going
run across
to
the
run
road.
because you're going to look first
Look both ways.
and look for danger. Okay, so you've got to your patient, and somebody mentioned primary survey already.
Yes.
Okay,
Yeah.
what is the next thing that you're looking for? So you've checked for danger, You go over, you're at your patient's side. What's the next thing? Dora the Explorer.
You're right.
Okay. Shout for help.
Happy day.
But did we check response scores?
Oh!
Whoa, okay. Thank you, Matt Palmer. Yasmin has just decided no response. Response?
I'm Order.
I'm so
Hello,
confused.
Order. I'm Jono.
Oh.
Comment.
Dad jokes.
Like and subscribe.
Get boots.
Get boots. Yes.
Right,
Yeah.
so
The next thing you want to do
check
is
response.
check response. Now, especially because we're thinking that they might be a spinal patient, it's really important that we approach them kind of from the feet upwards. You don't appear at the head. You don't kind of suddenly appear out of nowhere. You want to talk to them on approach. Say, hi, can you hear me? Are you okay? From a good distance away, so they don't get surprised and suddenly jerk away. Kind of straight from the start, say, don't move your head. Stay where you are. So you literally come up and approach from a distance. Say, hi, are you okay? I need you to not move. Stay exactly where you are. They'll know that you're there, and then hopefully they won't be moving. So you've got a response level out of them, but also you've already kind of started to protect that spine instantly because you've stopped any movement before you can kind of get there to hold their head still.
Okay.
Similarly, if you do suspect a spinal straight off the bat, walk up to them, introduce yourself from that distance, and then you should realistically get straight onto their head. Make sure you are immobilizing that before you do anything else. I mean, obviously, if you have to call the ambulance, get that phone out, put them on speaker, and then grab a hold of their head. Try and get a hold of their head as fast as you can because it minimizes the amount of time that they might accidentally move their head.
So this is basically all part of your kind of like looking for danger and checking their response. It's also like assessing the situation. So when you've seen someone being flung from a bike, what you should be thinking of is obviously their spine. Flung.
Thrown from a bike.
Okay, so the response is that he's alert. His name is Sam, which he told you, so that means he's breathing because he's also talking to you, which is great. Good stuff. Okay, so now you're suspecting a spinal injury. What is the thing you should do? Aaron gave it away just a minute ago, so I'm hoping you
can
got
I
it
just
right.
can I just address Cosmos? Yeah. If you've got a response, I mean, if you're walking up to them and you say hello, like I'm here, and they can hear you and you see movement, then in essence you're kind of assessing breathing at the same time. You can sort of assess your breathing as you're walking up to that patient. Am I right in saying that? You can assess everything as you're walking. Obviously, if they aren't breathing, don't go, oh, you're not breathing? Hang on, let me immobilize your head and then decide to do something else because it's not productive. But if you can see that they are breathing, but you still suspect a spinal, you get down onto their head before you do anything else, really.
Yeah. You should be able to see their chest rising, hopefully, when you get close enough. But also, if they reply to your questions, then you know that they're breathing because they're talking to you.
Yeah. And you can always do kind of further checks on breathing by taking your respiratory rates, and you can do some percussing and you can do some auscultation.
Yeah,
If
auscultation.
you really, really need, there are advanced kind of ways to assess breathing, but the real quick fix and the pretty certain one is if they are talking to you, they are breathing. If they are looking at you and maybe like making snoring noises, gasping, if you can't see them breathing, then they are not breathing.
Do we have any more questions?
No, that was the check breathing.
Oh, okay.
Right.
Cosmo didn't
Cool.
add question before his question.
Okay, so now that you've assessed, so you've done your primary survey, you're at your patient now. So what is something you can do now that you're there?
We've got answers already.
We've got answers already.
Yeah.
Yasmin,
Oh my God.
amazing.
So quick off the bat, guys. We didn't even have to wait then.
So we've already had
Correct.
Phoebe saying support his head, Yasmin describing supporting his head with the kind of spot finger split
hands.
thing. Because the last thing you want when you're talking to your maybe quite panicked, and I might be quite panicked if I got into any kind of spinal trauma, you're lying there. The last thing you want to do is then be like, okay, I'm going to stabilize your head. Let me just cover your ears. Because then they're not going to be able to hear you. They're not going to know what's going on. So you want to split your hands like this. And then there is a free to hear. Wow, profile picture. So that's really, really good. Matt, the response level is alert. So Sam is alert in this scenario. Lovely.
And part of your shouting for help is also calling an ambulance. When you suspect a spinal injury, you should be calling an ambulance pretty much straight off the bat. Yeah. So get your phone on speaker, put it next to you, and then immobilise the head. Because after you immobilise the head, you can't move your hands unless somebody else is there to switch over with.
Quick question.
Oh.
When you are immobilising their head
Yes.
and calling the ambulance, how should you position yourself?
Interesting question. What? Wait, is that
So
your
how should you
question?
position yourself if you have to hold on to their head,
Yeah.
call the ambulance? You don't know
Right.
how long they're going to be coming. You don't know when the ambulance can come. How should you
Okay.
position yourself to be able to stay on that head for as long as you can?
Oh, I got you.
Yeah. How should you position
We got
yourself?
there in the end.
Yes,
Guys,
that's
yeah,
Cool.
lie down. Lit times. Lie down. You can always put the phone on speaker, have it next to you, while lying down and immobilizing that head. We also have a quick question from Cosmo. It's a motorcyclist. How do we check for hemorrhages when the patient is wearing these big, thick motorcycle leathers? Really good question, because when you're going down your primary survey, spinal is a very important one, but so is any kind of catastrophic bleeding, so catastrophic hemorrhages. That's what we'd class as it's a major trauma. They're really, really bleeding out onto the floor or any of the body's cavities. Which are so. Should we talk about that?
I think we're kind of. I feel like we're really bouncing
We're
forwards and backwards
bouncing
on a
around.
lot. So maybe if
Yeah.
we just kind of.
Yeah.
So basically, you do your danger response. When you shout for help, ideally you get somebody else over. The really convenient thing about immobilizing somebody's head is it's not a skilled role. You can get any person who you believe to have any kind of capacity and competence to do it. It can be anyone off the street. Obviously, if they're kind of drunk or if they're the relative of somebody involved, then that's not ideal. But if you can get anyone off the street to kind of come in and clamp the head, that will free you up to do other things. You could also get, if I was on scene, Aaron was injured, I could get Annabelle to immobilise, I could get Emma to call the ambulance, and then I could be doing other things. That's why you call in as many people as you can. Sorry about it. Call in as many other people as you can to help you. That frees you up. Then when you do the airway, that's when because it's airway, but with like a small c for cervical spine. Cervical spine immobilization.
Yeah.
So you could get somebody to put their hands on and hold it in place. That's when you're controlling the airway. You might want to do a gentle tilt, or you could do a jaw thrust, and that's kind of how you would be able to assess their breathing. If they're not responsive and you're worried about their breathing, you would do a jaw thrust, get somebody in behind, immobilize their head, pop open their jaw, and then you can assess their breathing from that. So you don't have to do any head tilt chin lifts, but you've also got that C-spine immobilization. Then you do breathing kind of as normal. With the catastrophic hemorrhage, if you can see any kind of blood on the floor, or if they've lost a leg and you can see it pumping out, then it's obvious. But with the catastrophic hemorrhage at the doctor's CAB, the C is kind of if it's obvious, because yes, they might be bleeding underneath the leathers, but if you can't see it and it's not oozing out anywhere, it's not pumping out anywhere, it's either not catastrophic or like you just don't know about it. So obviously if there are any catastrophic bleeds, then fix that. Do your airways, do your breathing, and then as part of your secondary survey, once you've got them immobilized, you've made sure they're breathing, then you can strip them naked, get off all their leathers, and then have a good look to see if there's any bleeding, rather than kind of worrying about that before your airways. If you can't see it, it's not at that time. It's not an issue. So leave any kind of stripping and looking for any other bleeding until you've done your primary and secondary survey.
Also, I think bear in mind that you're on the phone to the ambulance service anyway. So if you're immobilising the head, like help is on the way, because you've got a suspected cervical spine injury, which is very serious, and people will be on their way quickly, hopefully. In the current circumstances, I'm not sure how quick that is going to be.
Oh.
But we have to ban that topic of conversation anyway. But and so if you're stuck there immobilising the head, they will be on their way. And so don't worry, hope is not lost, and somebody will be there to help.
Also, the whole point of having this acronym and the kind of steps to go down is because this makes it the most efficient possible. You kind of find it and you fix it. So You might not be seeing any kind of catastrophic bleeding now, but if they are bleeding in any way and it's not oozing out, maybe it is more of a minor bleed. I say minor, but it could be quite a lot. You'll get there eventually, and you'll get there quite quickly. It's quite fast to kind of complete your primary survey and then move on to your secondary survey. That's the kind of whole flow of it, so I wouldn't worry. And also, Annabelle's completely right, you've got help on the way. Right, so where did we get? We've removed the helmet, we're immobilizing, Sam's still alert, we're taking some obs. So their temperature is 37.2 degrees. Their pulse rate is 132 beats per minute. Their pain is 0. Sam's respiratory rate is 26. His pupils are pearl, so that's pupils equal and reactive to light. His oxygen saturations are 99%, and his blood pressure is 75.
Wait, I think it's the other way around. 112 over.
Oh my gosh.
112 over 75. I think.
I'd worry if it was 75 over 112.
Yeah.
I was like, great. So blood pressure is 112 over 75.
If you heard all of those obs, what do people think of them? Do you think they're okay? Do you think some are not very good? We can repeat them if you need to.
Did anything stick out from any of them? So temperature 37.2. Is that normal? Abnormal?
Thumbs up or thumbs
Thumbs
down?
up or thumbs down for temperature. Their pulse rate.
You're right.
Not bad for a guy being launched through the sky.
Yeah.
You are right.
Yeah.
Honestly,
Amazing. So pulse rate 132. Pain 0. A couple of you have brought that up. Yep.
Interesting.
Respiratory rate 26. Cool.
What do we think? 26 up or down?
La la la.
Sure, you're both.
Pupils, pearl, so equal reactive to light. Lovely. What might that indicate? What might it not indicate? Oxygen sats 99%. Is that good? Is that bad? Blood pressure is 112 over 75. What are we feeling? What are the general vibes?
26 breaths per minute. 26 breaths per minute. That's what 26 respiration rate
respiration
Breaths
rate
per
is
second.
breaths per
Oh my
minute. So does anyone know the normal range for respiratory rate? How many breaths per minute do people normally have? Correct.
No, we have to
That's
wait.
right.
We have to wait until someone says something and then say that's right.
I know, but Anna just goes minute. Yes, Eloise!
Yes.
Woohoo! 12
Eloise.
to
Oh God.
12 to 20 breaths per minute is the normal. So a respiratory rate of 26,
A bit high.
a little bit high.
Yeah.
Why might that be? Okay, so numbness, dullness, yeah. So a pain score of 0, considering that the mechanism of injury might be a little bit concerning.
And I think that's even more concerning because you're suspecting a cervical spine injury and he's not feeling any pain. You're like, oh, that needs to be investigated a little bit more, a little bit later down the line. So, yeah, bear that in mind because if he's just been flung from his bike, it would be, you would think that he would be in some pain at least.
It might indicate some potential nerve damage. So just remember the mechanism of injury has an expected result. So if their pain score is particularly low, it might indicate that something's not really firing in the right way. But at the same time, if his pain score is very low, maybe it's a lot easier to keep him nice and calm, which is good for now. Bigger pain receptors than damage.
Sometimes when you go through quite a traumatic experience like this, you might not feel any pain because you just had such a shock. So, so it could be normal, but just something to bear in mind. Yeah.
Okay, so those are all of his obs. Bearing that in mind, we've now gone to the second part of the secondary survey, so your head to toe survey.
This is like if you have somebody else with you. So if you imagine somebody else is immobilizing the head, and then you can do the secondary survey to give you a bit of context.
I love the formatting of this. It just goes exposed ? Yes. So yes, we will be exposing. So this is the point where if they've got some really thick motorcycle leathers, that's where you get to bust out your trauma shears and really, really, really work hard because they're very, very difficult to cut through. Motorcycle leathers are notoriously quite thick, so it might be easier to kind of try and like comfortable. You might want to kind of see if you can kind of quickly undo any zips. But yeah, you're going to want to kind of cut through everything, making sure you're preserving dignity. If you've got some blankets, make sure that it's underneath your patient as well as over the top. And such and such. Okay.
Trauma shears are the same as tough cuts.
Tough cuts
They
is
are.
just a
They're
specific
different.
brand.
Yes.
Different. Yeah.
We actually should call them trauma shears because Tough Cuts is a brand.
Yeah.
We're
So
not official representatives of Tough Cut, just trauma shears or raptor shears. Those are cool.
Oh yeah.
you get different kinds as well. Trauma shears are the general name. And you can get some very cheap ones on Amazon. You can also get some really, really nice ones, and they can just glide through like butter, and I love them.
Oh my god,
they're so cool.
Yeah.
So yeah, you're going to want to expose. That's where you're going to kind of be able to look for any kind of deformations, any kind of bleeds, grazes, strange bruised colouring. This is where you can palpate. You can kind of feel on their flesh a lot better. This is where you're going to want to be comparing both sides, looking for anything that's different, working from the head to the toes. And what have you found? You have found some swelling under the neck, some grazing on the upper left arm. His stomach is hard. We'll come back to that. But the stomach, when you palpate it, kind of working from the heel of your hand to the tips, like this, it's hard, it's firm. Grazing and embedded glass in his left hip, as well as a suspected fracture of his left ankle.
There's quite a lot going on here.
It's got a lot. Bearing in mind that when you did his observations, he had a 0 on the pain score. Might be slightly more concerned than we were before. So, general responses. Yeah, just like EpiPen is the brand of auto-injectors, Tough Cuts is the name for the general product. No, Tough Cuts is the brand name of trauma shears. Nice. Then, yes. Yeah, so Matt has brought up, and John has brought up some internal bleeding. So a firm, hard kind of stomach can indicate that something is there that's putting that pressure externally. Bearing in mind the mechanism of injury, it's probably not his lunch. Food kind of
Gas.
is quite soft
Gas.
anyway. It could be gas.
Yeah.
But bearing in mind here, we're working with a hard stomach. It's usually going to indicate that there's some kind of bleeding of fluid into his stomach as a cavity, and that's exerting a firm amount of pressure that's then causing you to kind of feel it and it be hard, which is worrying. Then indications of the swelling under the neck, that kind of supports the kind of trauma to his spine. Grazing on his upper left and the grazing on his left hip, as well as the embedded glass and the fracture of the left ankle, indicates that, number one, he has probably fallen and got most of the impact on his left side, just to bear in mind. But what are you going to do with the embedded glass in his left hip? What are you guys going to do to treat? Or are you not going to do anything? What you going to do with that glass?
So while somebody is immobilizing the head, these are all other injuries that you as first aiders and bystanders can deal with and
If
treat.
he's got glass in his hip through motorcycle lenses, you should be able to see that from the outside.
They might be quite big. I mean,
he's not wearing motorcycle leathers.
But you just said that he's cut his leathers off.
It doesn't say.
Oh, it doesn't say.
I'm
no,
saying
it didn't clarify
this.
He could be wearing jeans.
He could be wearing shorts.
Exactly.
You don't know.
You know.
Really shorts.
You should always be wearing leathers if you're motorcycling, though, right? You should be wearing
Correct. So to Yasmin, Cosmo, Eloise, Matt,
Yeah,
Phoebe, Yasmin again, Anna, and Anna again.
Oh my God.
You're all correct. Yeah, you don't want to take the glass out. Somebody's got glass in a wound, they need to have an X-ray to make sure that there's nothing. It hasn't hurt anything kind of internally. Also, you don't want to take, as true with any kind of embedded object, you don't want to take it out. You don't know how deep it is because you don't want to create any more bleeding. If it's nicked kind of an artery underneath and it's in place, it might be stopping any bleeding. If you pull that out, you might start more bleeding, so you want to leave it in place. Yeah. Put bandages either side so you kind of pad around it. And then you might want to kind of go over it or go around the limb. But it's really important that you pad either side and bandage the padding. Don't go directly over the glass. You don't want to push it in. but you also don't want to put it out. You want to leave it in place and support around it.
Matt's got a good
Matt's
question.
also got a question. Would you wipe the outside of the glass wound with antiseptic wipes?
It's a good question.
If you've got like dirt, and if there's like visible dirt around and sort of close to the thing, I would sort of, your best bet is probably wash with water. So rinse with water. If you think that there's a bit more to it and you want to sort of clean it a bit further, you can, but it's not like entirely necessary, because if you're cleaning around the glass, you have to be so careful that you don't, first of all, push it in further, second of all, pull it out, third of all, cut yourself on that glass. So I think the easiest thing to do would be just to flush that area with water if you do want to get rid of any dirt, and then pad it up and bandage it.
The thing is, at that point, an antiseptic wipe isn't going to do a lot. You know, they're going to need antibiotics. They're going to need kind of proper definitive treatment. As Aaron says, you might want to kind of wash away any obvious debris. If there's kind of loads of blood or there's dirt and that kind of stuff, you might want to get rid of that. As you said, kind of rinse gently with water. But going with an antiseptic wipe, A, is going to take ages. B, you've got a good chance of accidentally knocking out the glass if you're kind of trying to gently go around. Also, although I don't think they're feeling much pain in this scenario, if you wipe it with an antiseptic wipe, it can sting, it can hurt quite a lot. If they're spinally immobilized, or if you're kind of trying to be really delicate around that wound, if you're then causing pain and stinging and stuff, they might move, and you don't really want that. I just don't think that washing with a clinical wipe is
it's not really productive.
It's not gonna do enough, and you're kind of gonna maybe make it's definitely gonna make it harder, and it might make the situation worse. So I wouldn't bother.
Good question though, because as first aiders, you're like kind of trained that if there's a wound and if it's a dirty wound, you would try and clean it. But you know, in this situation, he's going to go to hospital anyway, and because there's a foreign object there, like Donnie said, he'll probably be on antibiotics, and they will clean it out, take out the glass for one, which we cannot do, but they'll sort that out later, to be honest. So while you're doing all of those little extra bits and you're wrapping him up and bandaging bits and bobs, you can also ask some questions for the secondary survey. What acronym do we use to ask the questions?
Secondary survey acronym. Yay, 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 yay. What is it called? Cha 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 cha.
I love your little songs.
No response.
I'm just reading this.
Oh, an irrigated wound. So when you irrigate a wound, it's basically when you're cleaning it. So you're adding some kind of cleaning fluid to a wound. So whether that be saline, whether that be water, whether that be some kind of like iodine solution, some kind of antiseptic solution. That's what we call irrigating the wound. So washing out any kind of dirt, debris out of the wound.
We got some good answers.
Okay, we've got some acronyms. The acronym ASHICE is for when you're handing over. So that's how you very efficiently hand over your patient to any kind of other person that's getting involved in your scene, whether that be a paramedic, a nurse, a fellow first aider. SAMPLE is the correct acronym. Woohoo! That's our acronym for doing secondary survey. Doing a secondary survey. Yes, that's my
Full
sentence.
stop.
There we go.
Full stop. So
signs and symptoms.
Yes.
You've covered that already. With doing all the head to toe examinations. You know what's happened, and you know that he's got the injuries that he's got. Yeah.
Everything.
Yay! And so he has an allergy to pollen. Sad times for spring. He's not taking any medications. He's not got any kind of past medical history. So he's not been going to the doctor in the past couple of weeks or seeing his GP. His last oral intake is, he had ham, egg and chips for dinner, which is very British.
Really?
Love ham, egg and chips. It's so
Nice. Maybe he went to
comforting.
Spoons. Oh, George's.
Ham, egg and chips.
So what is
If you have ham, egg, and
Well,
chips.
it's like
on
gammon.
a gammon? I've been one place and it said like really thin. It was literally like just like cooked like ham.
Oh,
like,
really?
ham. It's a bit strange.
Yeah. And also, you don't have gravy with it. You have
What
like a
kind of-
pineapple on it.
What kind of egg?
Just like
Fried
a
egg.
fried egg. Yeah.
We're really debating this dinner.
I've
huh?
never heard of this before.
Anyway,
It's so weird.
And he, in everything else, it pops up that Sam then turns to you and, doesn't turn because you're immobilizing him. But he then says that he can't feel his legs. So this in addition to the lack of pain and maybe the rest of the kind of indications from the mechanism of injury really, really, really corroborates the fact that he probably has damaged his spine in some way. There's some kind of interruption with his nerves. He's not feeling any pain. He can't feel his legs. He's kind of from his legs up, fine, but his legs down, not great. There also seems to be a little bit of a debate in the comments about what is encompassed in a secondary survey. So you've got your head to toe survey, which is when you're physically moving down, you're comparing sides and such. You've got your sample. They can be asking your sample. And you've also got all of your observations. So those three things paired together is the ideal secondary survey. And hopefully that's going to be done quite quickly as you move down. Again, when you find things, kind of treat it and such.
So next set of obs. Obs should be taken roughly like 10 minutes apart. Maybe you can do them close together.
You should do obs either every 10 minutes or every time you have made some sort of intervention on your patient. So if you have immobilized their head, you'll start with your you'll do your obs, and then if you go, let's bandage this, you do your obs again to see if anything has changed. Because what you're doing is trying to ensure that you have a sort of holistic view of the patient, making sure that you know what's happening and know whether what you are doing to treat that patient is beneficial and helping. So obviously, if they have a catastrophic bleed or they have some sort of major bleed, and you take their obs and they've got like a heart rate of 120 and a blood pressure that's like really tanked, and you stop that bleed or you make an attempt to stop that bleed, hopefully the second time you take that set of obs, their heart rate will drop slightly and their blood pressure will come up a little bit more, because you're reducing the amount of blood that is leaving their body, and therefore their pressure goes up and heart rate goes down, because your body should be able to contain the blood a bit better.
Yeah. So for the second set of obs, there are some things that have changed. So if you can remember the other numbers, we can tell you if not. Okay, so temperature is now 36.6, which has gone down. I think it was 37.2 before. Yeah, so it has gone down a bit. Comment why you think it might go down. Yeah, okay.
Okay, his pulse rate.
Is this the second? Yeah.
No, this is the first. So his pulse rate used to be 132, and now it's 68.
That is
boy, big set right now.
His pain is still 0. Respiratory rate has dropped to 17
from 26.
Yeah. Pupils are still pearl, which is good. Oxygen saturation still 99. That's okay. However, blood pressure, which was 112
over 75, is now 108 over 71.
What's really important about blood pressure is that if it's dropping or if it's low, it's an indicator that they are quite ill, and also now he has a much slower heart rate.
Okay, so we've just been asked what the normal blood pressure range is. It can really vary. It varies on age. It varies on individual. I would say that usually blood pressure is not 419 over 68. No, but the normal range is 120 to 140 systolic, and then the diastolic is usually around 80 to 90. So you're looking to be kind of 120 over 80 ideally.
The thing is, so
80 to 100.
80, it's 80 to 100. It's not 80
to 90.
I
don't know. Wait, what are our ranges?
80 to 100.
80 to 100?
140 over 100 is like your max limit.
That's hypertension.
That's hypertension.
Thing.
My blood pressure is like.
That's what you said, that's the range.
But that's
the limit.
I
140 over 100, it's hypertensive.
Is the ideal.
So
okay, that's
really
the ideal. The ideal is 120 over 80.
If you use that as your benchmark,
that's your ideal.
120.
But then your range is from hypo to hypertension, which is really, really low blood pressure, to really, really high blood pressure. Is the upper limit was 140 over 100? Did you say?
Yeah, I think so.
140 over 100. would indicate high hypertension, high blood pressure, and low blood pressure is kind of 110 over 70-ish.
The thing is, when you, I don't know if it's like relevant for St. John, but if you're kind of being monitored for your blood pressure anyway, and it's, you know, generally about 135 systolic, then your GP would probably give you some blood pressure medication for that. So, you know, 120 is your kind of benchmark, give or take, but you can go up a little bit. You can be like 126 or a bit lower, you know, 119 or something. And also it's useful to ask your patient if their blood pressure is normal to the one that you've taken. So if you're taking a blood pressure that's like 90 over 60 and you're like, that's really low, and they're like, oh, you know, that's normal for me, you're like, okay, that's a bit reassuring. So just check with them to make sure. And also if they have high blood pressure anyway and they're on medication for that, it's an important thing to ask.
Especially because if they haven't taken their medication, that can also cause any differences or discrepancies to their usual. So we've just had a very helpful comment from Ruba, and the NHS guidelines are ideal to be between 90 and 60 and 120 and 80, and that's what the NHS has said.
The NHS actually says, so kind of 90 over 60 is your absolute base limit, your lowest limit, and your maximum limit is 140 over 90.
Nice. Okay, so obviously it's very hard to set that limit because everybody's blood pressure is very different. If you take Jono's normal blood pressure and then compare it to my normal blood pressure,
oh, those are two different numbers, kids.
They're very, very different. I tend to run on a very low blood pressure, unfortunately.
I tend to run on a very high blood pressure, unfortunately.
So you've got the kind of two extremes, but that doesn't mean that one is healthier than the other. So long as it's your norm and your body is used to functioning on it, that's lovely. So very important to take that blood pressure. Bear in mind the guidelines and the ideal and the ranges, the differences in age and such, but then ask them what their normal is, as you've already kind of covered.
So Jay's asked, what are the two numbers? So yeah, you're super close. You get systolic and diastolic. So your systolic, which is the big number, so your 120, that is the strength that your heart contracts with. It's kind of how hard it pushes the blood out. That's your 120, and then your diastolic is how hard it kind of relaxes.
So how powerful your venous return is.
That's what it's relaxing.
Yeah, I'm just trying to put it
in basic terms. So it's like
we could go on for like
how
4 hours.
It's how strong your body can push the blood back into your heart.
So it's a measure on basically the key thing, especially in pre-hospital first aid, is your blood pressure is indicative of various functions, like whether or not your patient is maybe prone to fainting, whether or not your patient is maybe about to go into shock, because your blood pressure is very representative of the amount of fluid in your body. It's very representative of the amount of blood. So if your patient ever goes into hypovolemic shock, which your patient might be did I say that vaguely? Hypovolemic shock. That indicates that maybe there's been a very large amount of blood loss. It could also indicate that your patient has lost a large amount of other fluids, such as very, very chronic diarrhea or vomiting, or severe dehydration. It can kind of be represented by that blood pressure dropping, especially paired with that triangle of your blood pressure, your heart rate, and your, what's the other thing on the triangle?
Which triangle are you talking about?
There's like a triangle. I can't remember what the triangle is, but basically these things are linked. So it's like a seesaw. I think it's your general health.
The general health
triangle. The general health triangle. If your blood pressure is really dropping because you're losing a lot of blood, your heart rate will really increase to compensate for that. So your blood pressure is dropping and your heart rate is increasing. And that indicates that your patient is going into shock. So here, where your pulse rate has significant,
it's dropped
this one is
this,
dropped.
but normally with shock.
So for example, if you did have a patient who's going into shock, their heart rate is going to really increase and their blood pressure is going to really decrease. In this scenario, their blood pressure is kind of actually stagnated. It's kind of gone down by a couple bit of notches.
Welcome to Matt Mansfield.
Hi, Matt Mansfield.
Now joined in.
Welcome to the blood pressure debate. But so in this scenario, their blood pressure's only gone down a little bit. It's currently at 108/71. But their pulse rate has significantly dropped. So it used to be 132 beats per minute, and now it's 68 beats per minute. What might it indicate if their heart rate is really decreasing, but their blood pressure isn't yet? I'm waiting for them, but
right.
you.
I was reading
I'm waiting for them.
I was reading the comments.
Let's see what other people do.
I was just reading this conversation that's happening between Jay and Matt Palmer. It physically that's impossible. They can't have a systolic lower than their diastolic because of how the heart works. You can't have the blood returning with more force than it's pushing out because it's all.
It's one.
It's like hydraulic.
It's supposed to be a closed system.
Yeah. Like you can't, and like the way that you take a blood pressure, the highest number is always the one that you take for your systolic. So like, there's no way of knowing.
But
also an important point is that younger people tend to maintain their blood pressure quite well until they are very, very ill, and then they just completely drop. So basically, when you're going into shock, and you're and your heart rate is increasing and your respiratory rate might be increasing as well, then blood pressure will suddenly go down, and that's when you're like, this is really bad now, because their body hasn't been able to compensate for blood pressure, because that's what it will try and maintain the whole time, and that's why your heart rate goes up first before blood pressure starts dropping. Have we got any
Back
answers?
to the scenario.
Yes. An interloper. Oh. No, thank you for joining. Please all join. Tell your friends, tell your housemates. Fun activities. Right. So
I told my mum and dad that we were doing this, and I think they just ignored me.
If Annabelle's parents are watching, hi.
Hi, Mrs. Welcome. Right. So yes, the patient. So as a summary, to summarize for those of you who are joining, we've got our patient. He's called Sam. He's been flown off a
flown off a bicycle.
Flown off his bicycle. He's in the pavement, so no danger. He is alert. He's alert. He's breathing. You've already called the ambulance. You've immobilized. You've removed his helmet. You're doing a secondary survey. First set of obs, roughly fine. Pulse rate was very high at 132.
So was rest.
0 for pain. Rest rates were also quite high at 26. Pupils were pearl. Blood pressure was 112/75. You've now done your top to toe. You've exposed. You found swelling under the neck, grazing on the upper left arm. Stomach is hard, so indicates bleeding. Grazing and embedded glass in the left hip. You've got a suspect fracture of his left ankle. You've put on a cervical collar. You've cleaned and covered the grazes. You've tented the bandages. You've immobilized and supported his ankle. In sample, he's allergic to pollen. No medication, no past medical history. Last oral intake, he had ham, egg, and chips for dinner. But he also cannot feel his legs. You're now taking a second set of obs because you've done all these interventions, and there's a change in his legs. And his temperature is now 36.6, so slightly dropped. Pulse rate has also severely dropped at 68. Pain is still 0. Respiratory rate has significantly dropped from 26 and is now 17. Pupils still pearl. Oxygen sats have consistently been 99%. And his blood pressure is now 108/71. As a summary, so considering where we're considering
why his heart rate has dropped, but his blood
Right.
pressure stayed the same.
Blood pressure is the same, but his heart rate has dropped. What might that indicate? Paired with the fact that his respiratory rates have also dropped. Give him a high five.
Just a thought, but like barring everything else that is wrong with him, it could just because he's had a shock coming off his bike, and so his heart rate might have been very high because he was anxious and scared and worried about things as he came off his bike, and obviously had quite a bad accident. But now he's been lying on the floor for a bit. It could just gone back to normal. 68 is a pretty normal heart rate if you're fit and healthy. A little bit low, but yeah.
Sorry, I just want to address hello. The giving painkillers. In this situation, he's conscious and breathing, and he's also saying that he has a pain score of 0. So if he's not in pain, then I wouldn't Give painkillers.
Yeah.
Similarly, this guy has been thrown off his bike and you're suspecting a spinal. I wouldn't give him any sort of oral intake anyways, because this dude is going to hospital and he is going into surgery most likely. So giving him anything to eat or drink, painkillers included, will mess with that, and you don't want to do anything like that.
And also, there's a bit of a risk of choking as well if he's lying on the ground and you're trying to put paracetamol into it. It's just a bit, don't bother. It's a bit confusing, and it might go down the wrong way.
If you're an AFA and he's in pain, Entonox is your other option.
The other medical
Possibly.
gas that you might want to consider over any kind of painkillers, because he's not got any signs of pain, is oxygen. If he's had any kind of major trauma, including his spinal, then giving him oxygen can really help. His oxygen stats are 99%, so
Technically, you
don't need to titrate, but considering it's a major trauma,
it's
that
indicative
kind of
of
is
15 litres per minute oxygen
that
straight
would
off the
indicate
bat.
that just because of the damage that has been caused, the mechanism of it, that's why you would pull in your oxygen, even though his oxygen stats are currently fine. Okay, so where are we at?
We're an ambulance.
Okay, in our little sheet, the ambulance has arrived. So you've done all these interventions, you've taken these obs, you kind of decoded them as and when. We kind of covered this already, but what acronym are you going to use to efficiently hand over to the paramedic crew, considering that this is not a medical incident, but a trauma incident? I need like my own Kahoot background song.
Yeah.
Yeah. Okay.
Yeah.
So
Nice,
ash
nice.
eyes have been
Palmer.
shouted out quite a lot.
Back in with the ass.
But what's the other one that you can use that's a little bit more tailored to?
If you're a St. John volunteer, it's ash ice, whatever.
Which one are you talking
But-
about?
So I personally completely agree with that. It makes so much more sense.
Especially
It's
in
not
trauma.
an approved handover.
Is it not?
No,
So you can't use
ash
it at all.
ice, please, everyone. I know Atmos makes so much more sense. I completely agree with it. If you're handing over to a SWAS group, I would go with an Atmos, honestly. But St. John policy is
You
ash
do.
ice only.
Can we go through what
But
they
you
stand
do
for?
that.
Right.
I've seen you do that.
What does ash ice stand for?
So I can't say it. Ash
Ash ice.
ice. Okay.
Actually, can I just point out, while St. John's is ash ice, please do Nash ice.
Yeah.
Shout
So
out
it's
to
just
Cosmo
do
for
Nash
writing that.
ice.
So this is an interesting point, because if you're a St. John volunteer, they will usually ask for a handover like on the radio, and at this point you would not use Nash ice because you don't want to give a patient's name over the radio. But if you're just handing over to a paramedic and they're there right in front of you, and you have your patient right there in front of you, then you would use their name. But if you're over radio, don't give out like confidential information, which a name would be, because then you can identify the patient, which is not good for everyone else who is on the channel. And there might be quite a lot of people if this is a big event. But because we're not at an event, we're in a street on a pavement and the ambulance has arrived, paramedics are there, yes, Nash ice. So give their name, their age, Nas. Is it C or S?
It's an S.
It's an S. Is it sex?
Yes.
Yeah.
I forgot.
Yeah. Okay. H is for
History.
I.
I in the
Yeah.
injuries.
Or injuries or illness.
Injury or
Injuries or illness.
And then C cause for concern.
And then
And the event history, everything else. One of
Everything
those?
else.
Everything
Use
else.
everything.
Yeah. Okay. So
Shall we
go
it's
through that
really
again? We have
confusing.
reports that Jay is dying. I hope you're okay, Jay. Thoughts and prayers on you. I think
But also, well done for all of you who have typed it out. Perfect.
well done for all of you who beat Annabelle to ash ice.
It's okay.
I always
We
forget
get
that.
there.
I'm sorry, I'm not good with acronyms, guys. It's
So
a fault of
The real good thing, and the thing that I would always recommend kind of plopping in, even though it's not quite in there, when you start talking about the injury or the illness and then moving on to your cause for concern, pop in any major interventions you've made. So if you say, I put them on oxygen, say it there. It's quite good to have, especially for the paramedics. It's kind of like clear when they come over, but it's interesting to have, especially if you've done any major interventions such as splinting, or you've kind of tried to minimize any bleeding, and your patient is still deteriorating. If you've kind of stopped any bleeding, but they're still moving towards hypovolemic shock, that's where you kind of want to make sure that you've explained all of this. It's good to have a full picture. But
when you do a handover, work backwards from kind of the present moment. What we find a lot when people do handovers is they start kind of 10 minutes ago, half an hour ago, and the picture is very different now. If you've especially like if you've done like a resus or something, if an ambulance is called to a resus and by the time they arrive they're breathing, if you kick off with they're not breathing, it's going to scare people. Start off with what's happening at the moment and then kind of work backwards. Then it gives an accurate picture of the situation at that exact moment, because then you can treat based off of that rather than if you say, oh yeah, because in this scenario, if you said their blood pressure was whatever it was, 112, their heart rate was 138, paramedics are going to be thinking, oh, okay, bit high, bit fast, whatever. But if the current situation is actually that their heart rate is like 68 and stuff, then that's the exact opposite to the story that you kind of just told them. So start off.
And the thing is, like, when the paramedics arrive, they will be assessing the patient and taking their own observations as well. So if you're punchy with yours and give them the relevant information, then they'll take over and do their own thing as well. And things may have changed in that time as well. So just a reminder, it is not story time. So don't go back to the start. Just start where you are right now. Story time does not involve handover. Okay.
But yeah, that's why it's really, it's so important anyway when you're maintaining the health of a patient over a long time anyway to keep on taking those obs. But it's really good to document any changes to the paramedic crew, because Jono just kind of explained it, but if you flip that and you say, oh yeah, my patient was healthy and fine when I arrived on scene, oh yeah, now I'm resuscitating. They kind of need to know that you're resuscitating now, instead of, yeah, so her name's Doris, oh yeah, now she's not breathing. They need to kind of work with what it is at the time. Some people are asking whether or not saying the name replaces the S, so the sex part. It's always nice when you're handing over to bear in mind that there is a difference in biological sex and identified sex. Some people might introduce themselves to you, and if your patient says that they've got a preferred pronoun, that's a really nice thing to say in that handover, because you are handing this patient over to another kind of personnel, and it's really nice if we continue to care for them in the same way. So I would never kind of take away the S if it's going to help.
Also, there's a lot of names that apply to both genders, and it just doesn't work. Equally,
you don't have to say boy, girl, woman, man. You can always kind of go, yes, I've got Annabelle, she's a 20-year-old female, using female, male, it kind of flows with it, instead of just saying 20-year-old XYZ. Also, sometimes there are a couple of conditions that are kind of specific to biological gender. If I had Annabelle, a 20-year-old female, and she was complaining of pain in her stomach, and she's
I get where you're going with this, and it's okay.
There are some things where, okay, well, maybe it's just appendicitis, maybe she is pregnant.
Yeah.
It's important
You're pregnant until proven otherwise, is the thing.
Unfortunately, you are. In a certain age range, we do need to test it in hospital. But it's just important to have all of the kind of tick boxes, because in healthcare, we do need to know your biology. But also if there are any kind of preferences on pronouns and stuff, it's also very nice to know, so that you can have that really nice kind of bond with your healthcare provider. Because if you are in an emergency situation, as the patient, you might be quite scared, and it might be quite comforting to have people refer to you in your preferred way.
And it's also quite confusing as well if you go by a different name. If you go by your middle name normally, or if you choose a different name to go by, and then somebody's calling you the name you were given, it does get very confusing at that time. And the patients, if they're already confused, it's going to be like, are they talking to me? Are they talking to someone else? So be nice and be respectful.
And Annabelle is not pregnant.
I'm pregnant. Oh my god!
It's just that she was here.
Announcement, guys!
Gender reveal. Oh my god.
Oh my god,
yes, psych, it's the gender reveal part.
I would love that. Imagine a EUFAS baby.
Imagine if somebody's just logged on now, and it's like, wait, Annabelle's pregnant. Oh, she's not pregnant. Hi, Mr. Mrs. Fox. It's fine. It was a joke.
Imagine we've got so many baby Annie baby grows for our EUFAS baby.
Correct. On with the scenario.
Okay, anyway, so we're handing over.
We handed over, and they are going away.
And they've left. Great.
You
So
have done a great
you've done
job, guys.
It only took us best part of an hour to get there.
It's
Should
fine.
we talk through the other ones though?
Oh,
we're
Yeah,
going
so-
to take another like
Can I
hour.
make a proposition that we move on to the sofa?
Okay,
Yeah.
we're gonna
Because
move.
we've been sat on the floor for
strategically.
so long.
Oh, let's
My
let's
legs!
use
I
the
can't
whole,
move
like,
my legs! Oh
I
god.
can't feel your legs.
Oh god. Pain score 0. Can't feel my legs.
Wow.
Oh, we move on to the
Oh
sofa.
wait.
Oh,
this
wait, I
sofa-
thought we
were gonna go
this
there.
sofa-
This
Oh,
one's
we'll sit on
bigger.
this sofa.
Oh God, we're doing things.
We're doing all the things. It can't be. Yeah, lovely.
Wait, can you move it closer?
Oh God.
Oh no.
It's good. That's why we've got the comments up on our on my laptop there.
This is why, so that we can sit on sofas.
Just while we're going through, some people are asking about like the different roles in St John's. So you get a first aider, that's like your kind of base level clinical, and you get advanced first aiders, emergency transport attendants, emergency medical technicians. These are all going up, and then you get kind of paramedics and nurses who are on a par, and then you get doctors at the top. They don't kind of recognise like critical care paramedics and that kind of thing. But mainly it's first aiders, advanced first aiders, emergency medical technicians.
Mm-mm.
This is going to be snug. You can always just sit on the
I'll survive.
Social distancing, guys.
I'm
really not doing it
so
well.
uncomfortable.
We're all gonna be snuggled up here.
Yay.
Okay.
God help us.
Hello.
Can everyone
So-
hear okay? Can you thumbs up if you can hear us?
Jay asked if I want to play Mario Kart.
Yes.
You've seen the Wii
There's
wheel
a
in the
Wii.
corner.
Yeah.
I got a Wii in the PlayStation 4. I
Oh.
lived the highlight.
Also, slightly concerning.
We should just like,
Jono
turn it
is
around.
literally a pro at all of the Wii Sports.
Yeah.
games. And I'm literally like,
That's
okay. I think he trains for this. It's a lot.
It's
I also had to play the Wii tennis theme tune on the piano.
Amazing. You can hear us.
That's really
Oh, hooray.
sad.
Okay, cool. So we've just done our. What are you singing?
The Wii tennis song.
That's not the Wii song.
Yeah, it's the Wii tennis song.
That's
No,
That's Mario.
That's Mario.
Anyway, everyone's listening.
Okay, so yeah, I'm actually a grandma. Jono had to teach me how to do Wii bowling yesterday. Was it yesterday? I don't know, whatever the day it was. Right. Second scenario, different place, different person, different people.
Emma's such a boomer. Okay, boomer.
Oh, Emma, it's okay.
I'm 99.
Take it as a compliment.
You're 99.
I'm
I thought you were only
1999.
20.
Oh, you're
Well,
Ew. Okay. So scenario 2, electric googly. It's Freshers Week.
Dun dun dun.
It's around 11 p.m. Pretty early in the night, guys. And you are called to a patient who is throwing up extensively outside Unit 1.
Can we
On
just say
arrival.
that it's a Tuesday and Cheesy Tuesday?
Yeah,
is-
lit.
Don't
lit,
go
lit.
clubbing though, social
Look,
listening.
look, look.
Shout out to
Uptown
the
Girl
Lovely
is like shouting in the background. Whoop, 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 whoop. On arrival, you see a patient who is sitting on the pavement outside the club and is crouching over. What you gonna do? What you gonna expect? Hurricane Tortilla.
Or like hurricane.
Tortilla. I like it. That's such a run. Yes.
can confirm
Okay.
it's a long way to respond.
Lovely. Yeah, it is a very long way to respond because usually we're based in St. Mary Archer's Church, and then you gotta not run because when St. John you don't run, you
Walk
control
briskly.
walk. And bring all your kit to Unit 1. So it is quite a long way.
Yeah, the church is
but
opposite
you get
Fever.
there.
Yeah, so it's
Yeah.
it's a while. Past
Okay.
McDonald's.
So you've been called to this patient who's been throwing up. You get there, they're crouched over. Yasmin has said, check for danger. Yes, lovely, thank you. So you're going to check for danger, do your primary and secondary surveys. You find out that his name is Jack Fry. Their primary survey, they're alert and they're breathing and they are not throwing up. Nice.
Is there evidence of it?
Probably, I guess.
Probably.
Hey. Matt has brought up the fact that the vomit might prove a slipping hazard. That's actually not the worst thing to bring up. If you are going there, you really don't want to kneel down in the vomit. It happens.
That's why
It's
we're
a sad time.
chunky boots.
So we got fat boots. Yes, lovely. So secondary survey. You grab some obs and their temperature is 35.9. Their pulse rate is 114 beats per minute. Their pain is 0. Their respiratory rate is 17. Their pupils are both equal and reactive. Their oxygen sats are 97%. Their blood pressure is 143 over 94. And so as an AFA, you can take these obs. As a first aider, you can take the same obs, but without the blood pressure and without the O2 sats. What additional observation might you want to take for somebody who is throwing up, maybe acting a little bit drunk? What other observation might you want to have?
I've just thought of the wrong answer, and it's really breathalyzer.
Did someone measure the blood pressure?
Yeah.
Because,
Yeah.
yeah, good spot. It is.
Yeah, it's
it
a bit
is-
odd.
You're right.
Yeah, it is, yeah.
Something
It's
like that.
when you're 143 over 94 and he's 19, 18, 19. That's an abnormal blood pressure for, a young person. It's very high.
Temperature of 35.9. If it's 11 o'clock at night and they're out and they're drinking, well,
Suspect.
they may have been drinking. I wouldn't actually be very concerned with the fact that they're 35.9. I would make sure that we are aware of the fact they are outside and put something on them. But as we talked about in one of our previous sessions, taking a temperature tympanically, is that even a word? Using a tympanic thermometer isn't the most accurate thing in the world. So on the one hand, take it with a pinch of salt, but on the other hand, be aware of the fact they are outside and make sure they are going to be warm.
Yeah, I would say I wouldn't be surprised by it. I also wouldn't not worry. If somebody's kind of cold, you obviously want to make sure that they're warm, get a blanket on them or move them inside. It's not kind of critically urgent, but it's something to kind of really watch out for. Also with temperature, it's kind of relative. So if they're staying at 35.9, that's fine. You're kind of watching, see if it goes down.
Yeah.
That's kind of when you would start.
So we've had some good answers. Looking at
A
blood.
few of you have talked about eyes.
Just
Sorry, just cover that first. That's a really, really good one. One thing to kind of differentiate between a head injury and are they drunk is checking their pupils. You're looking for any reactions to light, both directly but also commensally. So in this scenario, they're both equal, they're both reactive. And you were going to say?
You got the fastness and blood sugars as well. Both those are good options for someone who's acting slightly erratic. Obviously, we can't do BM blood sugars, but it is a very useful tool. If you have an HCP, which is a healthcare professional, it's a great idea if you think they are acting erratic to get them to take blood sugar, because sort of drunkenness, confusion can be indicative of hypo. Wow, I forgot the second bit. Hypoglycemia. Hypoglycemia. Also, I mean, equally, the fastness is just as much as a good idea, because you can have similar symptoms if you are having a stroke. So getting either of them done is going to be in some way beneficial.
Lovely. Okay. So those are the obs that you've got so far. You're completely right. Yeah, their blood pressure is quite high. Their pulse rate's also quite high, but their pulse rate might be high for various reasons. Alcohol can be one of them. If they've just run outside, if they've just vomited, it usually tends to be quite high. Same with their respiratory rate. So their respiratory rate is 17, but it's a good thing to kind of keep an eye on. So your interventions, we talked about putting a blanket on them just because they're outside. You're going to want to take them to the treatment centre. So how are you guys going to get your possibly quite drunk and maybe unsteady on their feet patient to the treatment centre down the road?
John's asked a few times how old they are.
Oh.
Probably like 19.
I don't think it's said.
19
Yeah,
years
we'll
I'm
old.
going to say 19 years old.
That's
Sorry, John.
1-9. Just in
Repeat, John.
case. Thought maybe somebody was
1,
90 years old and
9.
out on a bender. Going back to John's point about him
Oh,
in a
has he
club.
said 3 times? Sorry,
Yeah.
John.
It could be me at Cheesy's old.
Yeah, so considering his the state of his blood pressure, you definitely need to be asking your sample questions and checking about any past medical history or any medication that he's on. And it could be due to like another health condition he has, but it also could be due to a problem that he's having at the moment. Cool. So for sample questions, his signs and symptoms is that he's got a pale, clammy face. Yeah. Whoop, whoop. And all of his obs as well can kind of be included in that kind of sphere. Allergies, he's allergic to penicillin. With this, I don't know, if you have the time to, and if your patient is, communicable, is that the right, I don't know, if you
Talking.
But yeah, talking.
Is a word that I think normal people.
Communicating.
Communicative.
Yes.
If they just talk.
thanks.
If they talk.
If they can make words.
Yeah, and if they're willing to communicate with you as well in a bit more detail, you could ask them what reaction they have when they do take penicillin, because if they get a rash or if they feel nauseous, if they have diarrhea, these are like kind of side effects, and it affects quite a lot of people, and so it's more like a sensitivity rather than allergy. But if they have, an anaphylactic attack after taking penicillin, then that is big boy, write down allergic to penicillin, capital letters. Yeah.
And it's good to know if they're carrying that EpiPen just in case as well. Medication, they say there are none. Past medical history, they've also said none. But their last oral intake was they had an apple for breakfast, had been drinking since lunchtime, and now we're here, boys, at 11 p.m. throwing
That's
up
such
outside
a
Unit 1.
classic of all of Freshers.
Oh,
Eating's cheating, the boys.
Oh my god.
Well, it does save money.
love it. Right, and then everything else, there is sadly, there is some vomit on the front of their t-shirt. Sad times for all.
As we like to see.
Not that. Okay, so we've got their sample. Let's say that we've got them back to the treatment centre. What are we going to want to do now that we've sat them down in the treatment centre? What's the thing we're going to do to the patient now? Ha 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 ha.
Did we work out how we were getting them back to the treatment?
Oh yeah, we did not.
We did.
It's okay.
Because Phoebe
Okay,
did
no, we did,
respond.
we did.
Did she?
Phoebe
What did she
said a
say?
wheelchair.
She said a wheelchair.
Yeah.
Someone also said a bicycle.
CRU.
Go on.
No.
Put them on the back
On
seat,
your
tell
bike.
them.
Not everyone can ride a bike.
Yeah.
And also, if they're drunk, they should not be driving. Please don't drink and drive. Bikes are still vehicles.
What else could you use apart from a wheelchair?
But yeah.
So abstract ideas, guys. What else could you use?
What else?
Not
could
too
you
abstract.
Not too
apart from
abstract,
a
still-
Things that we
wheelchair?
talked about in session.
Things that you would carry around as a first aider on a duty. Cha-cha-cha.
We do not
Oh,
carry
we
horses.
Well, like
Nice.
have on a duty.
Yes, we do.
Yeah, we do. As an aid, as an advanced first aider on a duty.
Stretcher, yeah.
not a bad idea.
If you have
Nice
one,
one.
that would be
If
a
you
nice
have one,
luxury,
yeah.
wouldn't it?
What up? Carry chair is a
Carry
really good
chair.
one. What else? Cha-cha.
Although a wheelchair is normally preferable to a carry chair to move for long distances. You just
Yeah.
don't want the chair for
Yeah.
Carry chair's better for this.
Yes.
upstairs and things.
Yes,
Well,
Yaslin, a carry sheet.
yeah.
Whoop, 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 whoop.
Oh.
A carry sheet would be brilliant. I'm going to ignore
That's
top. But thank you for your contribution.
It's
Well,
the
okay, a top.
I mean,
it's
like
the same basis.
a carry sheet is basically just like a reinforced like top.
Piece of top.
Yeah. But like,
Yeah, come
oh,
on.
you forgot the word. Okay, fine, forgive.
Forgive.
But just bear in mind-
If power has given you permission to be forgiven.
But just bear in mind, a carry sheet is reinforced and it's used to carry for a reason. The last thing you're going to want to do is just find any old swab of fabric and use that instead. You're going to want to use a proper, checked over piece of equipment, such as a carry sheet.
Complete cutaway. My mum's commented on this post. So, Mum, Helen, if you're watching, hi to you.
Hi, Helen.
See you tomorrow. Just so that she comments on the side, like,
Oh,
hi kids.
this is so
I
cute.
don't know if she knows.
Dang.
YouTube
We've got John as well. We've got Annabelle's parents.
I don't know if my parents are watching.
Dang,
They
this
ignore
is
that
lovely.
message.
Oh, EUFAS is a family. Okay, so we've transported to the treatment centre, preferably with maybe a wheelchair because it's quite a long distance. what are you going to do now that you've sat them down in the treatment centre? What
Use a
are you
stretcher for that
going
one,
to
because
do?
it's just a bit weird.
Not the couch you can, mate. Oh,
Is anyone replying?
give them a bowl. Don't let them.
Stop it, Matt!
Okay.
Go away!
Oh, okay. So, yeah, sick bag, give them a bowl. Might want to take a primary survey again. So they're breathing, they are alert. Well, no, okay, so sorry. Primary survey now, they're responding to voice, no longer just spontaneously alert, but they're responding to voice. They are breathing, but they've started to throw up again. You also notice that they're looking a bit cyanosed. For those of you who don't know what cyanosed mean, cyan is like a color of blue. So that's kind of how to remember it. But if you're cyanosed, it's like your lips start to turn quite blue. Maybe your extremities start to turn quite
It's like
quite
me
blue.
when I go in the cold instantaneously.
Yeah.
Go purple or blue.
Eye sockets get quite blue.
Any kind of like fine bits of skin or like extremities, they get quite blue due to kind of the cold or lack of blood flow. If you have quite a cold patient, their blood flow to the extremities kind of gets a bit shut off because they're wanting to prioritize the core. So their blood vessels kind of constrict and the blood doesn't get there anymore. So it doesn't look pink anymore. It looks quite blue. So it can be indicative of kind of quite cold patients or other things causing blood flow to be shut off. But yes, looking quite cyanosed, and they're vomiting again. So having a bowl or a sick bag handy is very, very helpful. Lovely. Yes. Your secondary survey, you're taking it again. Your obs are now temperature is 35.5, so gone down a bit. Your pulse rate is 56 beats per minute.
Jono's exasperated.
I don't think either, and the three of us between us haven't got a fucking word in it. We don't have the option. You just keep
My
talking.
laptop is running out of battery. Can I use your charger to?
Oh yeah, sure.
Thanks.
I'm gonna try to.
I think it's for this one.
We don't have the chance. You've got the thing in front of you. I can't see it. No, it's fine. It's fine. I don't want. I don't want to-
No, keep it. Emma,
Okay.
keep it.
I need to find plugs. Which one can I unplug?
One of the black ones.
Isn't one of them that